Hello and welcome. Thank you to Carolina Breast Friends and Nothing Pink for bringing us this very informative session tonight. Thank you, Dr. Gentile, for being with us. She is a breast surgical oncologist with Novant Health here in Charlotte, North Carolina. And we are excited to learn more about this clinical study for the BRCA study. Thank you for being here, everyone. Dr. Gentile, would you like to get us started?
I will. So thanks for having me. So we at Novant Health, we have a growing and pretty active research program, particularly within our breast cancer group, and that encompasses all of Novant Health, which includes the greater Charlotte market. We also have practice locations up in Winston-Salem, and then some of the outer smaller coastal markets are newer to Novant Health, but we have a pretty robust program within the Winston-Salem and greater Charlotte area. And we're lucky enough to have one of our breast oncology members of our breast program that happens to be involved in the Alliance, which is a big national clinical trials group nationally that we have, that we're able to bring these clinical trials locally. And so this is a really exciting trial that breast surgeons, breast oncologists, cancer doctors, and women and doctors and physicians and APPs that manage our high-risk populations are really, really excited about. And it's called the BRCA study, P standing for prevention. And so and I'm going to explain what all these words are, but the official title of the study is a randomized double-blind, placebo-controlled, multi-center international phase 3 study to determine the preventative effect of Denosumab on breast cancer risk in women carrying a BRCA1 germline mutation. So we will go through what all of that means throughout this short talk. But in general, as all of you all know, being involved with Nothing Pink, that women who have a BRCA gene mutation, particularly a BRCA1 mutation, do face an average lifetime risk of developing a breast cancer that's quite incredibly high, 50 to 87% in the various clinical trials looking at the risk. And this is compared to the average risk lady, which is 1 in 8. The risk that you hear thrown around during Breast Cancer Awareness Month, that translates into a 12 to 13% lifetime risk. So in this trial study, this is an international trial, so it's being performed on patients and women all around the world. And it is for women only right now, even though men can have the BRCA1 gene mutation, that breast cancer risk in men is much, much lower, even though it is elevated compared to average. So this is for women with a mutation in the BRCA1 gene. Ultimately, by the study's conclusion, they expect to enroll close to 3,000 women from around the world, and there are 30 different research sites in the United States. And so we're lucky enough to be selected as one of those research sites here in Charlotte. And so if the trial is successful, the goal and the hope is that future generations will have a new option to reduce their breast cancer risk without surgery, which, as we know, that surgery can have complications along with physical and emotional impacts, or at the very least, give some women more time when they find out about a mutation at a younger age before they move forward with their risk-reducing surgery. So the study question is, can the study medication, so this is a medication called Denosumab, and I'm going to go into what that is, decrease the chances of developing breast cancer compared to placebo in a woman who has a BRCA1 gene mutation? This is a bone building medication. This is an osteoporosis medication, and I'll kind of go through what that is. But we also are secondary questions that they're looking at is, can this medication protect bone health in the women who've undergone their prophylactic ovary removal or their BSO, or in women who have gone through menopause naturally. And so can this, when we remove the ovaries at a younger age, and we do see increased risk of osteoporosis from those hormonal changes, and the hope is that this would also have a protective effect on that. We do know that this medication is already used in women who are postmenopausal undergoing breast cancer treatment with aromatase inhibitors, which can contribute to bone loss. And this does have a protective and preventative effect in those women already. And that's been seen in studies of breast cancer patients. So what is denosumab? So denosumab is an FDA-approved osteoporosis medication. Hold on 1 second. If you guys don't mind, I'm going to just make sure I hear my daughter screaming and make sure she tones it down really quick. Okay, sorry about that. And so this is an FDA-approved medication to treat osteoporosis. And then the trade names that this goes by and that you may have heard are called Prolia, and another name is called Xgeva. And it's the same medication, but they're dosed a little differently, and that's where the names come from. And this is an medication used to treat osteoporosis is an injection. So it's a subcutaneous injection, and it's what's called an anti-resorptive medication. So it prevents the natural breakdown of bone cells. And so it prevents the development of osteoclasts. Osteoclasts are a type of cell in the bone that break down bone in part of the bone remodeling process. So it prevents the development of those cells, hence it's protecting the bone and preventing osteoporosis. And so this medication is actually what's called a monoclonal antibody. So it is a type of medication that will go into the blood and into the body and bind to this proteins found on the bone cells called the rank and the rank L. So rank and the rank ligand. So it's binding and blocking these proteins found on these bone cells. And so by doing this, this increases bone density, and in women with osteoporosis, reduces the risk of fractures. And so that's what it was most commonly used for and what it's been used for long term. And so then we say, well, how does this impact our breast cancer risk? And so some of this came from a common medication used to treat breast cancer. Estrogen receptor positive breast cancer is an aromatase inhibitor. And the way that medication works, it can lead to osteoporosis and bone breakdown. And so these medications, and this medication, Prolia, is used for osteoporosis. It's dosed, it's given as an injection, a 60 milligram injection 2 times per year to women with osteoporosis. And when they started giving this to women with breast cancer and studying the benefits of this, they also did see that this rank L ligand plays a role in the normal breast cell function. So it also impacts the way progesterone interacts with the breast tissue. And so in studies, starting in animal models and then in human tissue, in the laboratories, they've seen that blocking this ligand or this protein can potentially offer a novel approach for breast cancer prevention. And so when they've studied the blood levels and the tissue levels in BRCA1 and 2 mutation carriers, they found to have higher levels of circulating estrogen and progesterone found in the blood and in the breast tissue at various points in the menstrual cycle. And then in the studies of these proteins in breast cancer risk, they found that blocking this rank L protein pathway can inhibit or impact the cycle that leads to breast cell proliferation and cancer development. And so this is a little picture provided by the study that kind of shows a little bit of how this works with the picture. And they have found that the signaling pathways that play a role in the development of breast cancer and breast tumors involve this rank signaling pathway. Particularly, they've seen that this is associated with the development of triple negative breast cancers in BRCA1 mutation carriers. So the hypothesis is that if we can block this pathway, that maybe we can impact the development of triple negative breast cancer, which, as we know, there's a higher risk of triple negative breast cancer that we see in BRCA1 mutation carriers compared to the average risk population. And so far they've studied this in vitro and in vivo, means in a petri dish with just the individual cells. And then when they've looked at breast tissue in mouse models, they've showed that when they've targeted and blocked this pathway, they've been able to attenuate, which means lessen breast epithelial cell proliferation and reducing the risk of tumor formation, both in kind of in the petri dish in the lab and then within animal breast tissue. And so now we're trying to study that and translate that into humans and women. And so there's several different sub-studies that are also being looked at as part of the clinical trial. We are going to monitor, they're doing at some of the centers, not in Charlotte, they're doing specialized CT scans and bone density scans to see the effects on the bone density in premenopausal women. Currently for osteoporosis treatment, the drug is just used in postmenopausal women. We do use the drug in premenopausal women in the form of Xgeva. Xgeva was that other name for Denosumab, and that is actually used for bone protection in women who have breast cancer that is stage 4 with bony metastases. And so that's given to women of all ages who have bony metastases, and that's actually a higher dose. It's dosed 120 milligrams, and it's given once a month rather than every 6 months. And so we do know it is safe and it prevents fat fracture risk, bone fractures in women who have breast cancer metastases. But our hypothesis is that when administered as a preventative medication in premenopausal women, that it will improve bone health and skeletal integrity in premenopausal women, as we have seen in postmenopausal women. We also show that, and there's a hypothesis that the rank L ligand pathway can influence the epithelium, which is the lining of the breast, and potentially influence and decreased mammographic density. And we know that breast density is a risk factor for breast cancer, and breast density can also impact the ability and make it more challenging to detect breast cancer early on a screening mammogram. So this may work to lower cancer risk from those perspectives and improve our ability to just detect the cancers on screening. And then also looking at how this impacts the quality of life for women on the medication and not on the medication with regards to anxiety and comfort levels and side effects and all of that kind of stuff. And there's also some studies, a sub-study looking at circulating hormone levels and DNA levels that is available as part of the study here in Charlotte as well. So those are some of the other ways that they think the medication can impact women in the trial as well. And so a double-blind study means that when you enroll in the trial, neither the patient that is enrolled or the doctor or the physician that's alongside the trial will know which group you're in. So, and randomized means if you decide to take part, you're randomly assigned to a group. So that's done through a computer algorithm. And that's because we want the groups to be equal on both sides. And so when you're randomized, there's a 50-50 chance that you get into the arm 1 or one of the arms where you're going to get the study medication Denosumab, and then a 50-50 chance that you get into the placebo arm, which is a saltwater solution. And when I was talking this through with some of my medical oncologists, they said, I wonder why they need a placebo arm in this. Why couldn't everybody just get the medication? And they see, compare the risk of breast cancer development to historical controls. So that 50 to 87% that we know is the risk of getting a cancer. If we follow this group of women and they have a much lower risk, we'll know that it's successful. And they're doing this because they think if someone knows that they're getting the drug, that maybe someone knows they're not getting the drug, that may impact other lifestyle behaviors, such as if you know you're getting the drug, maybe you won't eat as healthy and do other healthy lifestyle behaviors that you do because you know you have this risk. And so they didn't want to kind of cloud or have any bias in those respects. They kind of want the women in both group to otherwise act the same and be the same in life. And so, as I mentioned earlier, the study is conducted by the Alliance Group, which is a group of institutions that run clinical trials in oncology, and it's funded by the Department of the Defense and supported by the NCI, which is the National Cancer Institute. So this is in the United States, a federally funded and supported study. This is the A211801 is called, as it means it's Alliance 211801. That's the name of the trial that you may see otherwise as well. And this is kind of how the trial works. We do have a baseline physical exam or clinical exam of the breast. You have to have a mammogram or an MRI within 6 months of enrollment, and we do a baseline blood work and pregnancy test. And then if you end up enrolling, there's a 1-to-1 randomization, meaning an equal number of people in the trial will go into the placebo arm versus the denosumab arm. And what we're doing is it's being given as a 120 milligram dose, which is a subcutaneous injection every 6 months, so 2 times a year for 5 years, compared to the placebo, which is also 2 times a year for 5 years. We do, and I think on the other slides I have what the follow-up and everything is, but we do ask you to come in for a follow-up visit while the patients are getting the treatments. We see you 2 times per year. And really, this is kind of going to be like a general follow-up high-risk visit that you would do before you had any risk-reducing surgery. We tend, our NCCN guidelines or national guidelines, and even us in our high-risk program, we recommend that you have a meeting with your physician and a clinical breast exam and follow up every 6 to 12 months. So we'd be doing this every 6 months on clinical trial and keeping up with the typical mammograms and MRIs as are recommended by national guidelines, and really kind of going from there. These are the inclusion criteria. So you do have to have your genetic testing results and proof of a BRCA1 mutation. This is going to be for women between the ages of 25 and 55 years old when you enroll. So if you're 55 at enrollment and you're 60 at the end of the trial, that's a-okay. I have some people on our list that are 24 years old, and we're going to get back in touch with them when they're 25. And you have to have a mammogram, like I said, and or MRI, but at the very least a mammogram within 6 months of trial that did not show any signs or concerns for breast or ovarian cancer. And we do ask that there's a negative pregnancy test. We don't want in that women have to use or contraception if they're of childbearing age to enroll in the trial. And then we don't want to have any preventative surgery that's planned. So if you said, I'm planning to have my surgery in 6 months or in 1 year, and that was kind of a set plan, we wouldn't want you to enroll. If you enroll in the trial and life happens and 2 years go by and things happen in your family and you decide that it is the right time for preventative surgery, that is okay as well. And you can, drop out of the trial and off of the medication and have a preventative surgery. So you're not prevented from doing that, but we just don't want to have that as a plan at the time of enrollment. And then exclusion criteria, because we're looking and talking about a breast cancer risk for women with intact breast, a prior risk-reducing surgery or bilateral mastectomy does include you. Having a history of a breast or ovarian cancer does exclude you. And then when women who are pregnant, lactating, or actively trying to become pregnant are excluded. Again, things happen, and if you become pregnant on the trial or decide you want to have a child or achieve pregnancy during the trial, if you're planning a pregnancy, you actually would come off of the medication for 6 months prior to trying to achieve a pregnancy. And then it can also, and there is protocols in place that if you have pregnancy and are concluded lactating, about going back on the medication. So also there are some women that do tamoxifen, raloxifene, or aromatase inhibitor as a chemo prevention or taking medications for prevention of breast cancer risk. And we just want women to be off of those about 3 months prior to randomization. And then if any patient is already on denosumab or any of the other bisphosphonates or osteoporosis medication, that would be an exclusion criteria as well. So patient registration requirements. So because we are conducting this through Novant Health, if you're not, we do have to have you to be able to enroll under the care of one of the sub-investigators for the trial. We do need the patients and women to establish in a high-risk clinic. And typically, if someone contacted us and we're outside of Novant Health or already not following in our high-risk clinic, we could actually get you in touch and have you get in touch and get all the information about the trial with our research coordinator, Josie. And then we would have you come in and have a visit as you would for any visit with our high-risk program to establish care. And then we could actually plan to meet you and enroll you during that visit as well. And that would kind of count as one of your annual follow-ups for the year. The research coordinator, Josie, would verify the eligibility requirements with you. We have to have that documentation and that genetic testing report with the gene mutation. And really, this is unfortunately the way this is not an industry sponsored trial. This is a cooperative group federally funded trial. So the drug is provided free of charge, but the follow-up visits, mammograms, and screenings would be kind of typical visits that would be billed to insurance. So we do like to verify that a patient has insurance and is aware of these costs, but it would be typical copays for visits and high-risk screening and all of that. So it does not actually include the coverage for that based on the way the trial is set up, and it's not sponsored by a big industry or the drug companies themselves. Really, it just is the typical follow-up that we would do per our NCCN guidelines. So we see our BRCA carriers in clinic 1 to 2 times a year already for a clinical breast exam, and we order and manage imaging 1 to 2 times a year. Most women do elect to do high-risk screening with mammograms and MRIs, each test once a year. And interestingly, MRIs are not required for the clinical trial. They just require at the very least a mammogram once a year. But I think most BRCA carriers tend to be very, very good with their screening. And then, like I said, once you establish with us, we do a baseline clinical exam and breast exam, and then once a year mammogram with or without the MRI. And we do see you 2 times per year. So we see you every 6 months, and that is during that visit, we'd have our high risk visit. And then we would administer the medication at that visit as well, which is a small subcutaneous injection. It's given in the upper arm, the upper thigh, or the belly, the abdomen. And over 5 years, the maximum total injections would be 11 total injections. The denosumab can lower calcium levels. So that's part of the annual blood work. We do blood work annually, and it's just the typical blood work that most women get with their primary care. And so we do, as long as that's being done and monitored 1 time a year, whether it's via primary care or via our clinic, to make sure that the calcium and phosphorus levels are all within normal range. And we do recommend that this is given along with calcium and vitamin D supplement. And so, as I mentioned before, we require contraception during the study and 5 months after cessation of the medication. And so generally, this medication is pretty well tolerated. And so my mother-in-law is actually on this for treatment of her osteoporosis. And really, people, when they're having it for osteoporosis treatment, have very, very little side effects. It is going to be a bigger dose that's administered twice a year. I was talking to a lot of my medical oncologists because they administer this and to their cancer patients all the time, and it's given at the same dose it'll be given in the trial, but they actually do it every month, and it's pretty rare that patients have any side effects. They said at most, some patients may have really mild bony pain, or it'll feel a little achy for the day after the injection, but that's really much more prevalent with several other types of injectable osteoporosis medications compared to the the Prolia or the Denosumab. The big thing that you'll read about when you read about Prolia, Denosumab, or Xgeva is something called osteonecrosis of the jaw. And this is actually something that is it's very, very rare. It only happens in 1% of women that take the medication in the first year of starting. But it's when it happens, it's a big deal. And so this is the one thing that even, when my mother-in-law was starting her Prolia, the big thing that people get worried about as a side effect. And the good thing is it's incredibly rare. We do just, in an ideal setting, you would be established and do regular dental care during the treatment period, which, visit your dentist 1 to 2 times a year for that preventative care. It's not required, but encouraged. And so that's really an overview. And so I put the website for the clinical trial up at the top right corner here. This is the number to my office. And I'm the principal investigator for the Charlotte market for the clinical trial. And so you can get in touch with us, send us a message, or email us if anyone was interested or wanted to have any more information. But I am happy to answer any questions or chat about anything from there.
Thank you. This is all so fascinating. I'll ask a question. As far as this being focused in the BRCA1 mutation specifically, was that, can you go into, do you know of why it wouldn't be BRCA2 or?
I know, and it's funny because I do, because we do see in general when we find genetic mutations or say of women who have breast cancer and we do genetic testing, we say that 10 to 11% of breast cancer is due to a genetic mutation. And of those genetic mutations, the BRCA1 and 2 make up about 6%. So we do find those most commonly, but we do tend to see more BRCA2s than BRCA1s, because even since we've opened the trial, I feel like everyone I'm seeing is BRCA2. So,
Right.
and it's really has to do with that rank ligand, and they think that that plays a specific role in the development of the triple negative breast cancer. So I think that's more why it is focused initially in the BRCA1 population, because I think it's specifically the hypothesis or the question in the hope and the goals is that this gives us right now we have nothing to prevent that. And in a general population of women where breast cancer risk, BRCA mutations or triple negative breast cancers only make up about 10 to 12% of the breast cancers diagnosed. In the BRCA1 population, it makes up more than 50% of the breast cancers that are diagnosed. So it's a much larger percentage of women within this population that could benefit from it. And then on the contrast, if you think of an average risk woman, so it's a good place to start with the clinical trial to see if it really has that effect. And if on the contrast to that, if you think about it, from our average population, when we have women who don't have mutations, but they have a high risk because of a strong family history, even with negative genetics, or they have a biopsy with atypical hyperplasia or atypical cells, those women could take tamoxifen or exemestane or some of those medications we use for treatment, which lower the risk of estrogen positive breast cancer, which we see in 85% of those women. So it's really just, and those are those were well studied many years ago in our prevention trials, our NSAPB P1 and P2 trials. So just like this is our BRCA prevention trial, and those trials were widely successful. Years and years ago, thousands of women did this for lowering breast cancer risk, and we saw that was vastly successful. So that's, the ultimate hope with this. I think it's definitely harder because it's a smaller population of women. And I think so far in the country, there is only 20 something women enrolled in the US. So we're really trying to get the word out about it and get people in. And I think it's hard because women, and you guys could comment on this. I see a lot of high risk women, and I think women who come in and they have a mom, a sister, or a very close family member that's gone through a diagnosis. they're the first ones to say with a new mutation, they're say, yep, let me meet with the plastic surgeons. Let's talk about surgery. And they're the ones that kind of will get to surgery a little quicker, maybe within the first year of diagnosis. Sometimes we have women that come in that their, cousin that lives across the country got breast cancer and got genetic testing and emailed, the 50 family members and say, hey, you guys should get this testing, but they're not really close with them. They find out they have a mutation. No one close to them has had breast cancer. And those are the kind of the people that are like, well, I would not do surgery. I'm going to just do this, my screening mammograms and MRIs. Most women are very, very good with screening. And I think, that's kind of the people that this would impact. So patients always struggle with, when do I do that surgery? And, very young women, when they find out, sometimes this could give them that option to say, hey, let me get through my childbearing and get
Sure.
to be a little older in life before I do my surgery. Because it's always a struggle, is when do I do this surgery? When is the right time? And
Exactly.
so, and then I think the trial will be nice because we'll see if we do see a reduction. Is that persistent? Is that long term? Can that
Right.
lessen the need for surgery for some people in general altogether? So
Yeah.
that would be
Do you think
something.
would the trial lasting at least 5 years, there wouldn't be any would you expect that there would be results or recommendations or use of the drug prior to the end of the study, or does it have to how
So,
does that
so sometimes I think, and it depends on the size of the study and the number of people involved. And so, because when they present follow-up results, it will usually be when they get a certain number of patients, and all clinical trials have these pre-specified time points at when they're going to run statistics. And a
Mhm.
lot of times it will be when the median follow-up, so when the average number of women get to 2 years or 2.5 years. They'll do a first thing or 5 years. And so there are some studies where we're getting some early 5-year follow-up, and they, started enrolling 15 years ago, but they just closed. So we have some studies, a study that closed about 2 years ago that at our big breast cancer meeting this fall, and this was not related to the BRCA gene or anything, but we got first median 5-year results, and it was 2 years after the study closed because they had good follow-up on the first half of the people that enrolled. So it will be a while.
Yeah.
They do see if there's drastic results. Sometimes they'll end studies early and put
Okay.
everyone on take all the placebos off and say, hey, you can go on this,
Yeah.
everyone can go on the drug, and vice versa. If I mean they're not expecting to see many negative effects. This is a really common medication. Um,
I was just gonna say, that's so wonderful that it's a common medication that's already being used and that you already have a sense of general side effects so that this isn't a totally new introduction and where people are trying to navigate what to expect in that regard.
Yeah, because to me, that's the first thing I would want to know. And I'm not gonna lie, I don't prescribe this. I'm not, so this is prescribed all the time by primary care physicians. Like I said, my mother-in-law's been on it for 2 years. I
Mm,
don't think she has any side effects when she gets it. And then our medical oncologists are actually dosing it at a higher dose more frequently. And they
mhm.
also administer some IV bisphosphonate medications for bone protection in women with bony metastases. And,
Yeah.
and so some of those actually have a lot higher side effect profile than the
Mm,
denosumab or the placebo. So I was kind of trying to say, I was trying, because I said that would be the one thing I want to know, right? If I was like, what do patients really have? And I have patients on it all the time, and they never mention anything or talk about it. So I
yeah.
think with a little bit of personal experience and then, talking with them, I mean, it's supposed to be very, very well tolerated. So they're not expecting to have many side effects from the injection or day-to-day side effects or anything like that. It would be pretty unusual.
That's good
Yeah,
news.
which beats the anti-estrogen pill prevention medications, which cause hot flashes and blood clots and things like that. So
I'm paying
definitely an easier sell from that respect. I think the harder part is it's a smaller defined population that we're looking at.
Yeah. Well, thank you so much. This was a wonderful presentation. Thank you.
Yeah, of course.